Dr. Amreen, can you hear me clearly? Or can we start the lecture? How many students are attending? Dr. Amreen, you can unmute you. You are muted. हेलो अच्छा ठीक है लेकिन मैं कह रही थी आपको आवाज क्लियर आ रही है ना ठीक है Assalamualaikum. Good morning everyone. I am Dr. Nuruddin. I am assistant professor from Pathology department and we will discuss the ischemic heart diseases including angina pectoris and myocardial infarction. If you have any queries during the lecture, any question during the lecture, you can ask in your chat box. And we will discuss at the end of the lecture or during the lecture. I will give you the answer of your questions. So let's start our today's lecture. Learning objectives of today's lectures are you will be able to understand at the end of the lecture about the angina pectoris, what are the causes, what are the pathophysiology of the angina pectoris, what is the acute coronary syndrome, and what is the myocardial infarction, its morphological changes in myocardial infarction, and sudden cardiac death, chronic ischemic heart disease, and few words, few lines about the cardiac stem cells. As you all know, this is the diagram of the heart and showing the coronary arteries arising from the aorta and encircling the heart. Okay, these are the aortic arch and different coronary arteries arising from the aorta. This is the left main coronary artery. This is the circumflex coronary artery. This is the left anterior descending coronary artery. This is here on the right side. There's the right coronary artery and posterior descending coronary artery. These all arteries are important because if thrombosis or embolus in any of these arteries can lead to the angina or the myocardial infarction. Okay, so what about the cardiovascular anatomy? As you all know, cardiovascular system has two major components. The first component is the heart. Heart has a four-chamber pump at the base, top of the heart, lies at the level of the sacrum, and it also includes the peripheral blood vessels. What is the purpose of the peripheral blood vessel? To transport and deliver blood to the body and to transport breast for the removal. Okay, there's the protection of the heart through the layers. There are the few layers of the heart. First is the pericardium. Pericardium is a protective sac around the heart. It protects the heart from the surrounding organs, surrounding areas. It is a protective sac. Epicardium is the outermost layer in which the coronary vessels lie on this epicardial layer. Myocardium is a thick middle layer of the cells in which the electrical properties, they have the electrical properties conducting system in the myocardium. And endocardium is the innermost layer. Innermost layer line the heart chambers in contact with the blood flow within the chambers. Okay, what is the ischemic heart disease? Can anyone tell me what is the ischemic heart disease? What is your concept about the ischemic heart disease? Can anyone answer me in the chat box? What is the ischemia? Very good applause. It is the lack of oxygen to the heart tissue or any tissue leading to the ischemia. There is a stopping of the blood to the tissues. You both are right. There is a low oxygen supply or the lack of the oxygen to the heart tissue. Very good. Ischemic heart disease represents the group of the syndromes resulting from the myocardial ischemia. It is an imbalance between the myocardial perfusion of the blood and the cardiac demand for the oxygenated blood. It is an imbalance. Because cardiomyocytes generate energy almost through the myocardial oxidative phosphorylation, and cardiac function is strictly dependent upon the continuous flow of the oxygenated blood through the coronary arteries. And as the cardiac myocytes generate energy through the mitochondrial oxidative phosphorylation, and they need continuous blood supply, continuous flow of oxygenated blood through the coronary arteries. So they are more prone to ischemia if there is a stopping of the oxygenated blood to the heart tissue. There are some rates of development of the ischemic heart disease. It depends on the number of the plug, atherosclerotic plug, their distribution, size, structure of the plug, degree of obstruction. Is there the incomplete obstruction or the complete obstruction of the coronary artery by the plug? Because in more than 90% of cases, ischemic heart disease is a consequence of the reduced coronary blood flow, secondary to the obstructive atherosclerotic vascular disease. So in 90% of the cases, the reason is the obstructive atherosclerotic vascular disease. Okay. We talk about the syndromes. Syndrome of the ischemic heart disease. These are the angina pectoris. What is the angina pectoris? Okay. Can anyone tell me what is your concept about the angina pectoris? Is there any difference between the angina pectoris and myocardial infarction? Just I'm asking because I want you to interact during the lecture and maintain the interest in the lecture. Mild heart attack with a pain in the pectoral region. Okay, let's start it good. Angina leads to MI. Okay, angina may lead to the MI. But what is the angina? Angina and myocardial infarction is the same or the different? Angina pectoris is a chest discomfort by the myocardial ischemia. Like after 15 minutes, angina leads to the MI. Very good. You all are right. If there is a pain, angina pectoris, pectoris, the chest, angina is the discomfort of the pain in the chest, and due to the myocardial ischemia. Very good. Okay, there is a clinical syndrome like angina pectoris. Angina pectoris is a chest pain, ischemia induced pain, but is insufficient to cause the myocyte death. Second one is a myocardial infarction. Third is a chronic ischemic heart disease. Fourth is a sudden cardiac death. Angina, you all told me about the angina. Angina is a chest pain, ischemia induced pain, but is insufficient to cause the myocyte death. Angina can be stable, acting at a certain level of the exertion. It can be caused by the vasospasm, vascular spasm, is the mental angina, and can be unstable angina, which can occur at the rest. Myocardial infarction is occurred when the severity or the duration of the ischemia is sufficient to cause a cardiomyocyte death. What is the difference? Angina is the ischemia of the myocardial tissue, but not leading to myocyte death. In myocardial infarction, ischemia leading to the cardiomyocyte death. Chronic ischemic heart disease, this progressive cardiac decompensation, which occur after the acute myocardial infarction, are secondary to the small ischemic insult, and it may precipitate to the mechanical pump failure, so it leading to the congestive heart failure. And sudden cardiac death occurs as a consequence of the tissue damage from the myocardial infarction. But most commonly, it results from the arrhythmias without the myocyte necrosis. It is a sudden cardiac death. There is a blockage of the artery by the embolus or the thrombosis can lead to the sudden cardiac death. Okay, what is the acute coronary syndrome? A list of the diagnoses that affect the cardiac system. Indicate an interruption of the blood flow to the heart. And stable angina known as ST elevation MI. And the ST elevation MI. What are the possible causes of the ischemia other than blood flow? In more than 90% atherosclerosis, vasospasm, and thrombosis. And there's an increased myocardial demand due to hypertrophy, tachycardia, hypoxia due to the anemia, lung disease, cyanotic heart disease. But 90% cause is the coronary arterial occlusion by the atheromachous plaque that undergoes an acute change atherothrombosis. Acute coronary syndrome occurs when a stable atherosclerotic blood is converted to an unstable, life-threatening lesion through the rupture, superficial erosion, ulceration. Acute coronary syndrome is frequently unpredictable and abrupt conversion of the stable atherosclerotic blood to the unstable, life-threatening atherothrombotic lesion. The following elements contribute to the development of the coronary atherosclerosis. What are the causes of the developing of the coronary atherosclerosis? Are the inflammation, thrombosis, vasoconstriction. Inflammation plays an important role at all stages of the atherosclerosis. Inflammatory cells are present during the all stages of the plaque formation. Okay, there is the interaction of the endothelial cell and circulating leukocyte, resulting in the T cell and macrophage recruitment and activation. And these cells activate the smooth muscle accumulation and proliferation, and leading to the erythromatous plaque. Inflammation plays an important role in the all stages of the erythromatous plaque. Second cause is the thrombosis. Second cause is the thrombosis associated with the eroded or the rupture endothelial surface, leading to the accumulation of the platelet aggregation and with the formation of the atheromachous plaque. And third is the vasoconstriction. Vasoconstriction directly compromises lumen of the diameter. There it causes the decreased lumen diameter. Vasoconstriction can be stimulated by the circulating androgenic agonist, locally released platelet content. Platelet releases different ADPs and different content to cause the vasoconstriction. An imbalance between the endothelial cell relaxing factors and contracting factors and mediated release from the inflammatory cells, they all can lead to the vasoconstriction. So remember, these are the elements for the development of the coronary atherosclerosis. Inflammation play an important role in the all stages of the this atherosclerosis. Thrombosis, when there is a rupture or there is a rupture or injury to the annular cell leading to thrombosis, due to the platelet aggregation, vasoconstriction, due to the different androgenic agonists and different content of the platelet leading to vasoconstriction and causing the decreased lumen diameter. So decrease the blood supply to the heart muscles. And one more thing in the inflammation, CRP, C-reactive protein, is the one of the simplest and most sensitive parameter. CRP is an acute phase reactant synthesized by the liver, and it can be increased in the MI or the angina. CRP is an important parameter to detect the inflammation or the infection. Okay, what are the acute plaque changes? If there is a plaque, it can be ruptured or refreshing. It can be erode, ulcerate, and expose the endocellular extracellular matrix, and it can lead to the acute hemorrhage. Okay, Abdul, I try to increase my voice tone. Dr. Amin, is my voice is not clear? Okay, I am saying acute plaque changes include rupture or the diffusion, erosion, ulceration, and acute hemorrhage. This is the picture. There is the rupture and the refreshing in the acute plaque. There is the hemorrhage in the plaque and erosion and ulceration. These are the acute plaque changes. Okay, this is a picture taken from Laura Robbins. Okay, this is the normal artery. This is a normal artery containing the adventitia media intima. Then if there is an atherosclerosis start, so there is the inflammation, there is a thrombosis, there is a vasoconstriction and leading to the lower lumen diameter. And this is the atherosclerotic plaque including a smooth vessel cell, lipid cells, and different inflammatory cells. Okay. It causing the fixed coronary obstruction, right? Causing the typical angina which occur on the exertion. If there is a rupture or there is a injury to the endothelial surface, it can cause the platelet aggregation. And if there is healing, there is a more decreased lumen diameter of the artery due to the platelet aggregation. And then there is a healing. Severe fixed coronary obstruction leading to the chronic ischemic heart disease. If there is a plaque disruption, if there is a thrombosis, neural thrombus with a variable obstruction or emboli, It can lead to the unstable angina. What is unstable angina? Can anyone tell me in chat box? What is meaning of the unstable angina? Mural thrombosis can lead to the unstable angina, myocardial infarction, or sudden death. And if there is a thrombus filling the whole artery, it is an occlusive thrombus. And acute transmural myocardial infarction and sudden death. It can lead to the sudden death. Very good, Abrar, without exertion. It means it can occur at the rest. No, Muhammad, when precipitated by the I am confused, sorry. Okay, right. One answer is a without exertion and one answer is a when precipitated by the exertion. Please remember what is the unstable angina. Can anyone answer? Sure. After saying angina non-zoning with rest. Anyone else? Again, unstable angina occurring progressively and it occurs even at rest without exertion. Okay. Remember, unstable angina occur at rest without exertion. The stable angina occur on exertion. And premental angina, which occur even at rest due to the vasospasm. Right, Nabira? Severe angina, even occurring at rest. These are the different manifestations. Fixed pulmonary obstruction causing a typical angina on exertion. And if there's a thrombus or thrombus, it can lead to the unstable angina that can occur even at rest. And the myocardial infarction or the sudden cardiac death. And if there's an occlusive thrombus, it will fill the whole artery. It can lead to the sudden cardiac death. The severe myocardial infarction. Coming to the angina pectoris. Angina pectoris, a chest pain. Okay, we already discussed angina is a suffocation, chopping, or pain, and pectoris is a chest. Chest pain discomfort related to the decrease in the oxygen-rich blood supply. Right? Angina is a medical term used to describe the acute chest pain and discomfort. Angina occurs when the heart need for oxygen increases beyond the level of oxygen available from the blood nourishing the heart. So there is a decreased oxygen-rich blood flow. Chest pain related to the decreased oxygen-rich blood flow. And usually due to the coronary artery disease, we already discussed in previous picture, there is a coronary artery disease leading to the angina and causes the atherosclerosis built up in many years, and it causes the narrowing of the lumen diameter. And atherosclerosis, what is arteriosclerosis? Arteriosclerosis is a thickening or stiffening of the arteries over a period of time, make them less flexible. They can all lead to the decreased oxygenated blood to the heart and leading to the angina. It is a pathophysiology of angina. Pathophysiology of angina is a plaque formation. Angina serves as a worsening that something is going on. This is the normal artery. This is the normal diameter of the normal artery. This is the arterial wall. And when there is a narrowing of the artery, this is the atherosclerotic plug, and this can lead to the decrease of oxygenated blood to the myocardium and leading to the ischemia and causing the angina. Okay, it has the three types: stable angina, unstable angina, and variant angina. Stable angina, people with a stable angina have the episode of the chest pain that are usually predictable, that occur on exertion, after exercise, after walking, after running, or due to the mental or the emotional stress. Normally, chest discomforts relief at rest, and nitroglycerin are both. If the patient taking the rest and the nitroglycerin, it can relieve the angina, stable angina. It is triggered by the exertional activities, and it is also increases by the emotional stress or the mental stress. Okay, unstable angina. What is unstable angina? It can occur at the rest. It is an unpredictable degree of the exertion or the emotion, more severe than the stable, and characterized by the increasing frequency and the severity, and provoked by the less than usual effort, can occur at the rest and interfere with the patient lifestyle. And variant angina, principal or the resting angina, it can occur at the rest due to vasospasm. Spontaneously with the, it has no relationship to the activity. It can occur spontaneously, occurs at rest due to spasm, and patient discomfort occurs at rest usually longer. Okay, this is a Victorian this is a picture of the three types of angina: stable angina, classical angina, effort angina. It occurs on the exertion. Unstable angina, which occur on less exertion or even at rest. Variant angina due to the vasospasm. This is the normal coronary artery. This is stable angina due to atherosclerosis. This is the unstable angina with the atherosclerosis with the blood clot, and the variant angina due to coronary vasospasm. These are the three types of the angina. I hope you all understand about these three types of the angina and can define these three types of the angina. I will ask at the end of the lecture. Okay, what is the clinical manifestation? You all know characterized by the chest pain, squeezing, burning, choking, or bursting pressure. It is quickly and slowly. Location on the left side of the chest, it can be the right or the left arm, shoulder, neck, and jaw, associated with the dyspnea, sweating, palpitation. Okay, what are the investigation needed to exclude the angina and the MI? ECG, electrocardiogram to see the ST segment elevation, coronary angiography to see the thrombosis size and distribution, and the stress test. Complication, it can angina pectoris can lead to the myocardial infarction or the cardiac arrhythmia because there is abnormal electrical activity in the myocardium. Now coming to the myocardial infarction, is there any question related to angina you can ask on the chat box? Okay, we have already discussed what is the myocardial infarction. Myocardial infarction is a disease condition which causes the release of oxygenated blood in the to the myocardium. Okay, if one question is ST-EMI, is the ST elevation MI? There are the two types of the MI. ST elevation, there is the on the ECG, there is the ST segment elevate in the myocardial infarction, and another type there is the no ST segment elevation which is the NSPEMI. So these are the types. These are the different types of the myocardial infarction on the basis of the ECG. Okay, myocardial infarction, heart attack is the irreversible damage. Okay, if there's insufficient blood to the heart muscle due to the narrowing or the thrombosis, may cause the chest pain, and they cause the cardiomyocyte death and the irreversible damage of the myocardial tissue caused by the ischemia and the hypoxia. When the coronary artery is occluded by the atherosclerosis and the involvus, it can lead to the permanent underlying blood flow to the myocyte and leading to the irreversible cardiac damage. Angina pectoris somewhat is a reversible cardiac damage, not the cardiac damage. It can revert. There's a picture where there's a blood clot and there's a cholesterol plug. It can cause the blockage of the artery, and these are the area of the perfusion. When there is a blocking of this artery, it can lead to the decrease or the stopping of the oxygenated blood and causing the cardiomyocyte death and dying muscle. Okay, what are the ischemic cascade? What is the ischemic cascade? Ischemic cascade, heart cells around the coronary artery die, and these do not regenerate. Following scar formation and the scarring decreases, risks for potential life-threatening dysarrhythmia. If the scarring increases, it can cause the dysarrhythmia. Weak muscles were vulnerable to the ventricular aneurysm or the rupture, and could rupture at any time. These are the complications of MI to the ischemic cascade. Okay, they classify on the basis of the anatomic clinical diagnostic information. On the anatomical basis, they divided the myocardial infarction on the anatomic basis, the transmural and the subendocardial. Transmural and the subendocardial. And diagnostic purpose, ST elevation cycle and non-ST elevation myocardial infarction on the basis of the ECG, on the basis of the electrocardiogram. What is the incidence and the risk factor? It can occur at an age. It can occur at any age. 10% chances in less than 40 years of age, and 45% occur people younger than age 65. And this chances and the rates of the myocardial infarction increases with age. And women are generally protected during their reproductive age. What is the cause of their protection? Can anyone tell me what is the protection of the women? But postmenopausal women have the increased risk of the MI, heart attack or myocardial infarction. Very good about estrogen. So in postmenopausal, there is no estrogen. They are more prone to the MI. Very good, Aksashraf. Very good, Luis. So this is a pathophysiology. I try to simplify this lecture because it's very lengthy topic in your textbook, Robbins. Okay, pathophysiology is there's a different cause. If there's an atherosclerosis, there's a gradual obstruction for many years. In some cases, it can be starting from the childhood. If there's an arterial spasm following a sudden reversible obstruction, if there's an atherosclerosis and there is a plaque formation and a plaque split and following a thrombus and involvus, it is a sudden, not usually reversible. So atherosclerosis, it is a gradual obstruction. Arterial spasm is a sudden reversible obstruction, and if there is an atherosclerosis along with the plaque split or the thrombus, it is a sudden and not really reversible, and it causing the occlusion. And these all three causes leading to the ischemia. When there is ischemia causing the hypoxia causing the reduced oxygenated demand, and it can manifest as an angina. If there is thrombolysis, not a thrombolysis, if there is a thrombus formation or the embolus, it can cause the unstable angina. Unstable angina, which can occur even at rest. And if there is a permanent thrombosis, so it can lead to the decrease or stopping of the oxygenated blood to the myocyte, to the myocardium, and causing the necrosis of the myocardial tissue and leading to the myocardial infarction. Okay, some other biochemical consequences of myocardial ischemia. When there is a stopping of the blood to the myocardium, ischemia, there is a cessation of the aerobic metabolism within cycle. Then there is an accumulation of the lactic acid. And myocardial contractility ceases within minutes. And loss of function actually precipitates the heart failure long before the myocyte death occurs. Before the myocyte death occurs, there is a loss of function of the heart due to the cessation of the aerobic metabolism. There is the accumulation of the lactic acid and decreasing myocardial contractility. So there is a decreased ATP and the increased lactate, and there the onset of the irreversible injury start. What are the ultrastructural changes within a few minutes? These are the including the myofibril relaxation, glycogen depletion, cell and mitochondrial swelling. And these early manifestations of ischemic injury are potentially reversible. These ultrastructural changes, including the myocardial swelling, glycogen depletion, and the myofibril relaxation, it can reverse if there is the early intervention occur of the myocardial infarction. Like angioplasty can occur before the irreversible injury, so we can revert the ischemic injury and revert the this ischemia. And when there is irreversible injury, it can occur approximately after 30 minutes. Thereafter, progressive loss of viability occurs that is completed by the 6 to 12 hours. If there is a reperfusion occur, the reperfusion benefit are greatest when it is achieved early, and are progressively lost when the reperfusion is delayed. So irreversible injury start after the 30 minutes, and the progressive loss of viability is completed by the 6 to 12 hours. So reperfusion is greatest if this is achieved early. If it is delayed, there is no benefit of the reperfusion in the irreversible injury. Okay, this is the aorta, this is the different right coronary artery, left coronary artery, this is a blockage in the right coronary occlusion, and this is the zone of perfusion to this area at risk. If there is a permanent occlusion for many hours, it can lead to the complete infarct involving nearly the entire area at risk. So this is the area of infarction. It is a complete blockage of the artery. So, meaning the areas of myocardium perfused with the major coronary arteries allow the correlation with their corresponding areas of myocardial infarction. If the coronary artery supply this area, so if there is a blockage in the right coronary artery, it can lead to the infarction of this area. So it depends on the artery's occlusion. Okay, what is the site of infarction? So this is the progression of the myocardial necrosis after the coronary artery occlusion. This is a 0 hour. This is the 0 hour. This is the a very early stage of the ischemic heart disease, obstructed coronary artery. This is the endocardium. This is the zone of perfusion area at myocardium, and this is the in the 2 hours. There is a starting of the necrosis. This is a zone of necrosis, and in 24 hours, this is a complete necrosis of this area, zone of necrosis of the myocardium. The area that depends on the occluded vessel for perfusion is apex myocardium, and necrosis begins in the small zone. A myocardium beneath the endocardial surface in the center of the skin zone. And the pattern of infarction depends on the location, size, morphological feature of the acute myocardial infarction, and on the multiple factors, size and distribution of the plaque, size and distribution of the involved vessels, and metabolic demand of myocardium, for example, by the blood pressure and the heart rate. There are the different arteries. So, left anterior descending artery of cause of 40 to 50% of the all MIs, all myocardial infarction. Left anterior descending artery is the cause of 40 to 50% of the all myocardial infarction, and typically result in the infarction of the anterior wall of the left side, left ventricle, and it can perfuse the anterior two-thirds of the ventricular septum. It can cause the infarction of this area, and most of the heart apex, more distal occlusion of stem vessel will affect the only apex. And the acute occlusion of the left circumflex artery in 15 to 20% of the cases, and right coronary artery occur in 30 to 40% is responsible. Right coronary artery is responsible of the 30 to 40% of the myocardial infarction, and it's much affect the right ventricle. And the if the right coronary artery is affected, it affects the right ventricle. If the left coronary artery affected, it can affect the left ventricle and the apex of the heart. Okay, this is the type that I am taking from the another article, another presentation. These are the types of infarct according to the anatomy region of left ventricle involved. It can be the anterior infarct, posterior infarct, lateral infarct, septal infarct, circumferential, and combination of the anterolateral, posterolateral, and septal. It depending on the artery which supply which area. So it depends on the area of the occlusion, and according to degree of thickness of ventricular wall, it can divide into the transmural. Transmural means there is an involvement of the full thickness. Full thickness, whole myocardium. Then laminar is the subendocardial. Subendocardial is the beneath the endocardial. Just remember the name. Most important is it depends on the degree of the thickness of ventricular wall involved. Transmural is the full thickness, and laminar is the subendocardial. So they are the pattern of infarction. Pattern of infarction include the transmural infarction, subendocardial infarction, and the multifocal microinfarction. Okay, Abraham. So there are the three types of pattern infarction: transmural infarction, subendocardial infarction, and the multifocal microinfarction. Okay, this is the picture taken from the robots. Okay, these are the transmural infarct, and this is a non-transmural infarct. Transmural infarct is the permanent occlusion of the left anterior descending branches. It can leading to this area of the infarct, right? And there is a permanent occlusion of the left circumflex branch. There is a permanent occlusion of the posterior descending branch of the right coronary artery. So this is the right ventricle, this is the left ventricle. Okay, if there is the All three arteries are blocked: global hypertension, circumferential, subendocardial infarct. And they are the small intramural vessel occluding myocardium. It can lead to the sudden cardiac death. Let's talk about the morphology of the myocardium during and after the myocardial infarction. The broad and microscopic appearance of infarct depend on the duration of the survival of patient after the MI. MI less than 12 hours usually do not appear on the broad examination. They appear as the normal heart tissue. So this is the cross. If the infarct preceded death by the 3 hours, it is possible to highlight the area of necrosis. This is the area of necrosis, yellow area, brick red color. This is the intact myocardium, and infarct appears as an unexplained pale zone. They look like as a pale zone. This is the area of the infarction. Then, if the 12 to 24 hours infarct appears as a reddish blue area of discoloration caused by the trapped blood, stagnant blood, and they are progressively more yellow and tan. And by the 10 days to 2 weeks, it is rimmed by the hypertrophic zone of hylovascular accumulation tissue, and there is scarring. After 10 days to 2 weeks, there is a scarring of the heart muscle and evolve into the fibrous scar. Okay, this is a microscopic view of the different infarct. If there is a 1-day-old infarct showing the coagulative necrosis and the baby fibers. These are the baby fibers elongated and narrow and appear with the normal fibers at the right. Okay, widened spaces between these are the widened spaces between the dead fiber contain the edema fluid and the neutrophils. These are the neutrophils. These are the blood cells. These are the normal structure of the myocardium, and these are the damaged structure of the myocardium. There is an interior space between the dead fibers containing the edema fluid and the scattered neutrophils. This is a 1-day-old infarct. Remember all these pictures. It can help you to remember the different morphological features of the myocardium. This is the 3 to 4 day old infarct. These are the fibers, myocytes, and these are the leukocyte infiltration. Polymorphonuclear leukocyte infiltration, meaning the neutrophil infiltration in the 3 to 4 day old infarct. These are the 7 to 10 days. There is a removal of the necrotic myocytes. There is a decrease of the myocyte on this picture. This is the 7 to 10 days old infarct. There is a removal of the necrotic myocyte by the phagocytosis. There is a picture of the 7 to 10 day old infarct. There is no myocyte, losing most of the cells and phagocytes. Then after 10 to 2 weeks, there is the increasing the granulation tissue. These are the granulation tissue characterized by the loose collagen fibers and abundant capillaries. These are the small capillaries. There is the development of the granulation tissue after 10 days. And after 2 weeks, healed myocardial infarct, necrotic tissue has been replaced by the dense collagen scars. And residual cardiomyocyte cells show the evidence of the compensating hypertrophy. So this is the healed myocardial infarct, necrotic tissue replaced by the dense collagen scar. These are the chart which showing the summarize the morphological changes in the myocardial infarction. Okay, at 0 to half hour, no cross features and no microscopic findings found. And this is the time of the reversible injury. If there is an irreversible injury, in half 4 hours, there is no gross features, but usually on the waviness of fibers at the border occur at the 4 hours. Then 4 to 12 hours, there is a dark mottling, occasionally dark mottling of the heart tissue, and there is the beginning of the coagulation, necrosis, and edema hemorrhage. Then in 12 to 24 hour dark mottling of the heart tissue, and ongoing necrosis, hypnosis, and there is a neutrophilic infiltration, 1 to 3 days, yellow infarct, and coagulation necrosis, loss of the nuclei. 3 to 7 days, there is a yellow tent softening, and there is a beginning of the disintegration of the dead myofibers, and phagocytosis occur at the 3 to 7 days. In 7 to 10 days, well-developed phagocytosis of the dead cell, and there is the early formation of the fibrovascular granulation tissue occur. As we have seen on the picture, on the 7th day, there is a granulation tissue start. Then after the 2 months scarring complete, and there are the dense collagen scars seen on the microscopic finding as seen in this picture. This is a more than 2 months scarring complete. Okay, there are some release of the cardiac marker. Cardiac marker after the acute myocardial infarction. What are these markers? What is the more important marker in the myocardial infarction? Okay, these are the CKMP. Right, very good. Approach CKMP drop. Okay, CKMP in 6 to 12 hours. Okay, this is the line of CKMP. It occurs in the 6 to 12 hours, peak between the 12 to 28 hours, and return to normal level in about 72 to 96 hours. And the myoglobin elevate in 1 to 2 hours. Myoglobin occur in the 1 to 2 hours and return to normal in 10 to 15 hours. And the tropi is more important in the myocardial infarction. Troponin T and troponin I levels increasing at the 3 hours and peak at the, this is the trop T, 14 to 18 hours and elevated till 5 to 7 days. Okay, these are the ECG findings. ST segment elevation, T wave inversion, and appearance of the white deep blue Q waves. You remember these changes. Okay, ST segment elevation, T wave inversion. Okay, this is the ST segment elevation, T wave inversion, and the appearance of the white deep Q waves. This is the normal segment PQRST, and this is the ST elevation. This is the S and this is the T. This is elevate in the myocardial infarction. Okay, and this is the decrease PQRS complex. What is the treatment? Treatment if the myocardial infarction suspected in hospital or on arrival. You can give the GTN spray, oxygen, pain relief, then admission to the hospital. And here you can start the aspirin. During hospital admission, you can add the beta blocker as inhibitor and consider the revascularization like angioplasty, stenting, arterial bypass. And in long term, you patient put on the aspirin, beta blocker, and the SC inhibitor. Glyceride trinitrate spray. It can occur in our setup. We can give the GTN tablet, glyceride trinitrate tablets. Okay, this is the picture showing the percutaneous angioplasty. This is the artery, this is the black, and you put the stent and inflate the balloon and remove the balloon, and this is the flattening of the artery. What are the complications of infarction? Ventricular rupture, papillary muscle rupture. Okay, this is the cardiac rupture. This is a complication of the myocardial infarction. This is the ventricular septal defect. These are the papillary muscle rupture. They can all complicate the cardiac. This is the side of the hemorrhage. Okay, these are the mural thrombus. And this is the left ventricular aneurysm due to the weakened blood vessel. This is the ballooning of the blood vessel. What is the chronic ischemic heart disease? Is a consequence of the accumulated ischemic myocardial damage and inadequate compensatory response. Okay, we have only 2 minutes. And chronic ischemic heart disease typically appear post-infarction. due to the functional decomposition of the hypertrophic and the different contraction defects. Okay, what are the cardiac stem cells? Cardiac stem cells, it is a new term and it is on the basis in the myocardial infarction. Because the serious morbidity associated with the ischemic heart disease, there is a much interested ability of the cardiac stem cell to replace the damaged myocardium. This is the new term used in your book. And this is the one stating cardiac stem cell and their role in the myocardial infarction. And they lead to over the past decade, stem cell therapy emerged as a novel strategy for the patient with ischemic heart disease, and its beneficial effect have been demonstrated by the substantial preclinical and clinical studies. Efficacy of the several types of stem cell in the therapy of cardiovascular disease have already been evaluated. However, repair of the injured myocardium through stem cell transplantation is restricted by the critical safety issues and ethical concerns. So it is on the trial basis. These are the two different links of the cardiac stem cell. If you are interested, you can go on this link and you can read about the cardiac stem cell. What is the role of the cardiac stem cell in the replacement of the injured myocardium? These are the references. Thank you. Any question you can ask in chat box. We have almost no time, but you can ask question in chat box or you can mail me.